Ayan, recording. So, we'll tackle hypertension, heart failure, ischemic heart disease, and arrhythmia. So first, we'll tackle hypertension, the most common disease among Filipinos and worldwide. No? So ano nga ba yung blood pressure? So blood pressure composed of cardiac output and total peripheral resistance. Cardiac output determines the systolic pressure. Diba, ang BP, we have the systolic and the diastolic. So the cardiac output is the systolic pressure, which is the amount of blood pumped from the heart per minute. No? And it is influenced by the heart rate, contractility, and blood volume. Hence, cardiac output is equivalent to stroke volume and heart rate. Stroke volume determines the contractility, preload, and afterload. Stroke volume is the amount of blood ejected from each ventricle per beat, no? And the total peripheral resistance determines the diastolic pressure determined by vasoconstriction. And hypertension is the most common cardiovascular disorder. Check the light. It's the most common cardiovascular disorder. So it is defined as sustained BP greater than 140/90. And usually they are asymptomatic. And if left untreated, may lead to myocardial infarction, heart failure, stroke, and kidney disease. And it has a strong correlation with metabolic syndrome. So metabolic syndrome like diabetes, obesity, and the likes, no? Which so metabolic syndrome is a cluster of conditions that when occur together can increase the risk of diabetes and heart disease. I remember dito lang this week lang, no, I have a patient, no, na ang BP niya 190/110 pero wala pa rin siyang nararamdaman. As in, wala lang. Gusto niya lang magpag-BP that time. Tapos na-detect, first time niya na-detect to 190/110, no? Nag-try na kami mag-rest and all, hindi pa rin bumababa. So that is an asymptomatic, no? Kaya usually ang hypertension, tinatag yan na stridor na sakit. Ayan. Specific cause of hypertension can be established in only 10 to 15%. So pag yung patient walang definite cause of hypertension, it is called essential or primary hypertension. Pero kunyari merong if the patient has a specific etiology of etiology of hypertension, it is called secondary hypertension. For example, ang hypertension is due to high cholesterol, that is secondary hypertension. Okay, pero may mga patients parang fit, no? Sobrang lean ganyan, pero ang BP ang taas, no? So it is possible na walang definitive cause, pero yun yung tinatag natin na essential hypertension. And the diagnosis of hypertension is based on repeat, reproducible measurements of elevated blood pressure. So, minsan, pero as we doctors, no, hindi kami nagda-diagnose ng hypertension na ngayon, mataas ng BP, pero first time lang tumasan. Hindi. Dapat repeated yan and reproducible. Ibig sabihin, nauulit, no? So, we diagnose tayo hypertension pag yung may episodes ka na pag ganyan, first episode mo pa lang, we encourage BP monitoring, no? Pero pagka kunyari, nagpapa-BP po ako, lagi naman po 140/90. Minsan nga po nagwa-160. Pero wala naman po akong ginagawa, okay naman po ako. So pag mga ganyan, we outrightly start no? Antihypertensive medication. And it serves primarily as a prediction of consequences for the patient, and it certainly includes a statement about the cause of hypertension. So based on the American Heart Association and American Stroke Association, this is the cutoff of the categories for blood pressure. So less than 120/80, and less than systolic of less than 120, and diastolic of less than 80 is the normal BP. Elevated is at 120 to 129 over less than 80. High blood pressure is when patient is at 130 to 139 over 80 to 89. Hypertension stage 2 is 140 or higher or over 90 or higher, and patient is now experiencing hypertensive crisis if BP is at 180 or higher and higher than 120 over a diastolic of higher than 120. No? And usually mga patients natin, no, kahit mataas usually tatanungin, Dok, paano po namin malalaman kung high blood na po kami? Usually monitoring lang talaga and screening, no? And usually mga patients na-experience nila yung mga nararamdaman pag na-stroke na sila, nag-atake sa puso na sila, no? And this is very alarming dahil nga at age 25, meron na akong patient na stroke in the young. No? Bumababa talaga. Meron akong peer age 30, atake sa puso. And these are adult illnesses, no? Diseases na dati sa matanda mo lang yan iisipin. Pero ngayon, bumababa na due to lifestyle diseases. And the strategy for BP is, di ba, BP is equal to cardiac output plus APR. So that our strategy is to decrease yung cardiac output and at the same time, increase APR. So kasi pag bumaba to, decrease ang BP. Pag bumaba to, decrease ang BP. But not both all at the same time. Kasi ang problema niyan, ang ano natin, hindi naman pwedeng bagsak na bagsak. Either i-target mo yung cardiac output or target mo ang TPR. Yeah. So the American College of Cardiology and American Heart Association recommends SBP over DBP or systolic over diastolic of less than 130 over 80 as a general treatment if tolerated. No? And on the other hand naman sa European Society of Cardiology or European Society of Hypertension, they recognize that the target is less than 140 over 90 with a lower target of 130 over 80 for patients with diabetes or renal disease. So this is the in general the recommendations for the general recommendation for different hypertension classification. So for patient with normal BP, we promote optimal life habits. So reassess after one year. But if the patient has an elevated BP, we encourage non-pharmacologic therapy, exercise, lifestyle change, no? Then reassess for 3 to 6 months. If the patient is classified as stage 1 hypertension, no, we assess for the clinical risk for stroke, no. If the patient has a CVD risk of greater than 10%, we will start with non-pharmacologic therapy and BP lowering medication. Pero pag walang risk of we are not meron kasi kaming classification on how we will predict stroke, no, in 10 years if the patient has no risk, as a risk of less than 10%, no, non-pharmacologic therapy will do. Kasi minsan may mga patient, pwede po bang lifestyle disease, lifestyle change pa rin po? Pagbabasketball na lang po ako. E paano po hanggang during habang nagbabasketball ka bigla kang natumba, no? Kasi lalo tataas ang BP mo habang nagbabasketball ka. So that is very alarming, and pag sa pharmacies, you encourage your patients na magpa-consult sa doctor. Okay? And for hypertension stage 2, no, we outrightly recommend non-pharmacologic and BP lowering medications. There are 4 major drug categories under antihypertensive agents. We have sympatholytics, diuretics, direct vasodilators, and agents that block production or action of angiotensin, or the RAAS. So for sympatholytics, so they lower the BP by altering sympathetic function, and they are most effective when concomitantly used with the diuretic. So we have the first one, we have centrally acting or the alpha-2 agonist. The examples are methyl-dopa, clonidine, guanabens, and guaifenesin. So the most commonly used in this group is methyl-dopa, no? Usually sa mga pregnant hypertensive, clonidine, no, for yung mga ginagamit ng mga lola natin, nanay natin to immediately reduce BP, no. So the mechanism of action is that it acts on the presynaptic alpha-2 alpha-2 agonist to decrease norepinephrine release, no, in the synaptic cleft. So the activity of methyl-dopa is that it stimulates the central alpha adrenoceptors by alpha methyl-dopamine and alpha methyl norepinephrine. So this is the schematic the formation of norepinephrine, no? So initially it's formed from tyrosine, from dopamine. Then dopamine is converted to norepinephrine and enclosed in the in-enclose siya to a vesicle, no? Then through the action of the calcium, extracellular calcium, no, it will extravasate, no? This vesicle will extravasate to be released here in the area for norepinephrine to attach to the receptors, no? To a photoreceptor here. So the action of methyl-dopa is that it is converted into alpha-methyl-dopamine and alpha-norepinephrine, which are an analog, or they have the same structure of norepinephrine. Therefore, it replaces norepinephrine in the receptors, no? And it is released by nerve stimulation to interact with postsynaptic adrenoceptors. However, this competitive inhibition or parang replacement of alpha methyl norepinephrine to the norepinephrine is not responsible to the antihypertensive effect of methyl-dopa, but instead it acts on the alpha adrenoceptors to create or to mediate the peripheral sympathetic constriction of arterioles and venules. Hence, no, it will create an antihypertensive effect. So, ang important na maalala nyo is that methyl-dopa is the one that is given to patients with hypertension during pregnancy, and clonidine is used for patients who has not responded adequately to the treatment of diuretic or beta blocker. So in terms of clonidine naman, So clonidine binds to the imidazoline receptor to create an antihypertensive effect. Side effects include methyl dopa. When patients taking methyl dopa, it can cause sedation and positive Coombs test. So yung Coombs test, yun to yung test natin for hemolytic anemia. So relatively, pwede mapagkamala natin yung patient na may hemolytic anemia if yung patient nagtitake ng tawag dito, ng methyl dopa. Clonidine, on the other hand, also can cause sedation, dry mouth. Important is rebound hypertension. Ibig sabihin on withdrawal. Kaya hindi natin ina-advise na lagi natin painumin yung patient ng clonidine. Pero sayang sayang ang benta. Dami kasi bumibili ng catapres eh. Yun na lang mabenta sa clinic. Pero yun nga, syempre, if you will look on the benefit of the patient, hindi siya magbe-benefit doon, and it will further aggravate yung pagtaas ng BP if the patient persistently takes clonidine. Kaya yung clonidine hindi yan ina-advise na i-maintain unless prescribed. Okay? So next we have alpha adrenoceptor blocker. So we have a non-selective, alpha-1 and alpha-2 inhibitor, phenoxybenzamine and phentolamine. These are used for the management and diagnosis of pheocytochroma. Alpha-1 blockers on the other hand, pag alpha-1 blockers, they are selective, sabihin kasi alpha-1 lang, So yung mga suffix niyan include sucin, prazosin, terazosin, doxazosine. So alpha-1 blocker, decrease vasoconstriction. Pag decrease ang vasoconstriction, decrease ang TPR. It is used for primary hypertension and for benign prostatic hyperplasia. Pag nakakita kayo ng mga patients na naka-terazosin, prazosin, and doxazosine, yung ginagamit niyan for BPH, yung mga lumalaki ang prostata. So the important side effect is that yung orthostatic hypotension, especially after the first dose, baka may lumapit sa inyo, nahilo ko, ganyan, Biglang pagkainom po nahilo po ako. Yun yung possible niyan, orthostatic hypotension. Ibig sabihin nun, there's a decrease of blood pressure, at around 10%, by 20%, usually 10 millimeter to 20 millimeter mercury upon sitting up or standing from sitting up to standing up, parang ganun, or changing position. For example, bumangon kayo, yun yung usually kaya medyo may hilo. Yung biglang bago kayo, biglang bago yung position. So nagbabago kasi ang BP natin when we stand up or we change in position, There's ang nangyayari, yung katawan natin has a difficulty to adjust pagka nagbago tayo ng position. So yan, orthostatic hypotension. And usually you can experience patient experience dizziness or restless, parang weakness after. Pero after some time kaya minsan di ba pagkatayo nyo, pagka nakaupo kayo for some time, medyo nag-o-okay na yung ulo. So that is why, yan yung yung orthostatic hypotension. Beta blockers. So beta blockers decreases heart rate and contractility, therefore it decreases the cardiac output. It blocks the stimulation of the renin secretion, and it is used for primary hypertension. So these three, bisoprolol, carvedilol, and metoprolol, are stable beta blockers that The based on study is beneficial for patients with severe heart failure, no? Take note lang, no? These three, bisoprolol, carvedilol, and metoprolol, sila lang yung may study for heart failure patients. Yung metoprolol, particularly metoprolol succinate, no? Kasi usually ang available sa market is metoprolol tartrate, no? Metoprolol succinate. Bisoprolol, carvedilol, metoprolol succinate. Sila yung ginagamit for heart failure na beta blockers. There are different characteristics of beta blockers. One is selectivity. So selective meaning it targets beta 1, no? Beta 1 receptors, no? We have betaxolol, bisoprolol, esmolol, atenolol, acebutolol, metoprolol, and celiprolol. So yung acronym niyan is BIMC. We have non-selective, ibig sabihin it targets B1, B2, and others are combination of alpha and beta. We have propanolol, pendolol, cartiolol, carvedilol, labetalol, timolol, and nadolol. Okay. Also, we have intrinsic sympathomimetic activity. Ibig sabihin ito, these are group of beta blockers that can simulate beta adrenergic receptors as an agonist effect and can oppose the stimulating effects of the catecholamines as an antagonist effect. So we have pindolol, pendolol, acebutolol, cartiolol, timolol, and labetalol. And also we have patients, we have beta blockers with membrane stabilizing activity. So membrane stabilizing activity involves inhibition or total abolishment of action potential being propagated in the membrane, no? That can prevent the impulses in the periphery of the in the central nervous system. Hence, the block of the action potential is the propagation of the action potential is blocked. No? And, these are indolol, propanolol, betaxolol, metoprolol, and labetalol. So the newer class of beta blocker, we have nebivolol. So nebivolol is a third generation beta blocker which exerts a nitric oxide mediated vasodilation aside from its beta blocker effects. So kung yung nebivolol, actually sa patients ang ganda ng effect, no? Yun nga lang medyo mahal. Pero when it comes to BP lowering, it is very beneficial. However, beta blockers are contraindicated for heart failure patients, for congestive heart failure. So, ibig sabihin, patients with on congestion, no? Pag congested yung patient, hindi tayo pwede magbigay ng beta blocker, and pag bronchoconstriction as in the case of asthma and COPD. Kasi, di ba, lalo na yung mga yung mga non-selective, kasi di ba beta 1 heart, beta 2 lungs. So pag dinak mo din yung beta 2, edi hindi na makakahinga yung patient. It will further aggravate difficulty of breathing. And also hypoglycemia. So next we have diuretics. Diuretics decreases sodium and water retention. Pag decrease ang water sa circulation, decrease ang blood volume, therefore decreases the cardiac output. So the example of these group of drugs are thiazide diuretics. So we will also discuss na rin yung ibang types of diuretics here. We have carbonic anhydrase loop diuretics, thiazide diuretics, potassium sparing, and osmotic diuretics. But the most in this group of sa hypertension, thiazide diuretics lang ang beneficial sa hypertension. Okay? Pero, sasabay ko nang i-discuss. So, yan. Number 1, we have carbonic anhydrase inhibitors. We have acetazolamide, dorzolamide, and brinzolamide. So, the area in which it acts, the area in which carbonic anhydrase inhibitors act is on the proximal convoluted tubule. No? So in the proximal convoluted tubule, no, where there's the presence of this carbonic anhydrase. So this is the one that causes conversion of this of acid, no? Hindi ko na masyadong i-discuss yan. Basta ang important na alam mo that the carbonic anhydrase it is found in the proximal convoluted tubule, no? And the examples are acetazolamide, dorzolamide, and brinzolamide. So it is important for the management of glaucoma, for urinary alkalization, metabolic alkalosis, and acute mountain sickness. Side effects include metabolic acidosis, hypokalemia, renal stone formation, hypokalemia, drowsiness, and hypersensitivity reactions. However, it is contraindicated for patients with hyperammonemia with hepatic encephalopathy in patients with cirrhosis. So next we have loop diuretics. We have furosemide, the most common, I mean. Furosemide, torsemide, bumetanide, and itaclinic acid. It is among the most efficacious diuretic agents available. So, kung yung carbonic anhydrase natin is found in the proximal convoluted tubule, so loop diuretics is found in the third acentic limb of the loop of Henle. It decreases sodium reabsorption by inhibiting the sodium-potassium chloride transporter in the loop of Henle. It can cause acute pulmonary edema. It is indicated, I mean, acute hypercalcemia, hyperkalemia, acute renal failure, and an iron overdose. However, it may cause hypokalemia, autotoxicity, hyperglycemia, hypomagnesemia, and allergic reaction. The third one is thiazide diuretics, no? They are the ones used in hypertension. So kung makikita nyo, yung suffix may is thiazide, no? Except for yan, indapamide, chlorthalidone, metolazone. So these are thiazide, these are all thiazide diuretics. So thiazide diuretics acts in the distal convoluted tubule by increasing the urinary excretion of sodium and water. By inhibiting sodium chloride's importer. So it is used in hypertension, in heart failure, nephrolithiasis, and nephrogenic diabetes insipidus. So among the diuretics, no, siya lang yung nagkakos ng hypokalemia. Lahat nagkakos ng lahat pwedeng mag-cause ng hyperkalemia. So ito lang yung pwedeng mag-cause ng hindi, wait lang. Hypokalemia din pala. Yung potassium sparing pala yan. No? Ibig sabihin ng spare, ibig sabihin iniwasan niya yung potassium. No? We have spironolactones and eplerenone, amiloride, and triamcinolone. So it occurs in the collecting tubule, inhibiting sodium reabsorption and potassium secretion. So also it is combined with loop diuretics, thiazide diuretics to prevent potassium loss. It is used in hyperaldosteronism, And among the diuretics, ito pala, and among the diuretics, potassium-sparing diuretics is the one that can cause hyperkalemia. Okay? Metabolic acidosis and gynecomastia, yung spironolactone particularly can cause gynecomastia and kidney stone formation in terms of the kidney. So pakitandaan yan. No? Siya yung magkukos ng hyperkalemia, yung potassium-sparing diuretics. The fifth type is osmotic diuretics, mannitol and urea, which has an osmotic effect in the proximal convoluted tubule and the thin and descending limb of the lobe of Henle. This increases the urine volume and reduces intracranial and intraocular pressure. So usually ito ginagamit natin as a medical decompression sa mga stroke, hemorrhagic stroke. No? May relative ba dito na meron bang relative, nagkaroon ng relative ng stroke? Na ano, yung hemorrhagic stroke, kasi dalawang stroke. Wala. So, yun, no? Kung mapapansin niyo yung mga gamot na binibigay natin, we give mannitol for patients with hemorrhagic stroke for decompression. In effect, makikita nyo na marami ang urine volume. And it is important na i-monitor natin yung urine output ng patients during administration of mannitol. Yan. Side effect include extraocular volume expansion, hyponatremia, somehow hyperkalemia, and hypernatremia. Vasodilators, we have hydralazine. Hydralazine directly relaxes arterioles to decrease total peripheral resistance. So mapapansin nyo yung mga mechanism nila, it's either to decrease cardiac output or to decrease total peripheral resistance. No? It is used for patients with hypertensive emergency, particularly in pregnant women. So usually yan pag mga OB patients, yung mga pregnant women, no, na matataas ang BP, hydra, binibigay na sila, no? Pag mga patients sa kayang outpatient, minimethyl-dopa yan ng mga OB-GYN. However, the side effect includes reflex tachycardia and SL-like syndrome, no? Kaya maalala nyo yung HIP, di ba? We have HIP, hydralazine, isoniazid, and procainamide. Yung tatlo na yun are notorious in causing SLE-like signs and symptoms. Reflex tachycardia, ibig sabihin nun, yung palpitation, magkakaroon ng rebound palpitation. Kung kanina sa clonidine, may rebound hypertension. Reflex tachycardia naman tayo sa hydralazine. Okay? Minoxidil. Yung minoxidil, alam nyo, saan nyo siya na madalas nakikita? Sa mga buhok, di ba? Pampakapal ng buhok. Or minsan nilalagay yan sa mga basta yung mga regrow, di ba? Familiar kayo? So, minoxidil is initially used, no, as antihypertensive before siya ma-realize na it can improve parang hair development, no? So, the active metabolite is minoxidil sulfate that directly relaxes arteriolar smooth muscle that decreases TPR. It decreases renal vascular resistance and it is used for more severe and drug-resistant form of hypertension. However, the side effect is hypertrichosis. Next, we have sodium nitroprusside. So it has a potent effect on arterial and venous system to decrease the peripheral vascular resistance and venous return. It is used for hypertensive emergencies and severe heart failure. However, it can cause hypotension if not monitored, cyanotoxicity, and arrhythmia. Ako personally, no, hindi pa ako nakagamit ng sodium nitroprusside, no, in my practice. Next is diazoxide. So it is also formerly used for for hypertensive emergencies pero ngayon hindi na yung ginagamit, no? But also it also have a direct action in the arterioles to decrease total peripheral resistance. It can cause hypoglycemia due to It is used also for hypoglycemia due to hyperinsulinism. However, side effects include hypotension and hyperglycemia. So ngayon, ginagamit na lang siya to treat hypoglycemia, no? By hyperinsulinism caused by insulinoma. Insulinoma is a mass in the pancreas, no? So nangyayari, yung mass nagpupulos ng sarili niyang insulin, no? Kaya tumataas, nagkakaroon ng hypoglycemia yung mga patient. May mga ganun talagang so yun yung ginagamit natin, diazoxide. Pero hindi na siya ginagamit for hypertensive emergency. Ibig sabihin ng hypertensive emergency, no? Yung BP more than 180 yung kanina, yung crisis. Baka nakalimutan niyo, baka salita lang ako ng hindi pala nag-gets. So basta yung emergency, yung mga sobrang taas ang BP, no? And ang goal natin kasi dyan, pag mataas ang BP, syempre papababain. Pero not to the extent na papababain mo siya to normal, no? Kasi pwede siya ano pa? Yes, oo. Pero currently mga na lang ginagamit natin, calcium channel blockers. Pero kasi ito yung nasa book nyo pa rin, kaya dinidiscuss natin. So phenoldipham, so these are peripheral arteriolar dilator for emergency hypertensive emergencies and post-operative hypertension. However, it can also cause reflex tachycardia and can increase intraocular pressure. And yan. So currently, we are using calcium channel blockers, no? Particularly itong dihydropyridine, no? It is important to note that the first generation dihydropyridine is nifedipine. And the second generation is amlodipine, felodipine, isradipine, nicardipine, and nisoldipine. So calcium channel blockers inhibit calcium channels in the arteriolar smooth muscles. No? It has no cardiac effects. And however, it can cause peripheral edema. So mapapansin niyo may mga patients pag nasa practice na kayo, no, may mga patients na currently ang tagal na naka-amlodipine, no, felodipine, tapos sabi ni Coco-Pleaser, Dok, nagmamanas po kami. Ano po bang pwedeng ipalit? No? Siyempre, relatively pa mga ganyan. Siyempre, at a pharmacist perspective, no? Siyempre, ituro sila na magpakonsult sa doctor. Siyempre. Pero yun nga, pag mga ganyan kasi, we opt to change, no? Pinapalitan na namin yung calcium channel blockers into other types of antihypertensive. So usually, yung mga emergency na drugs na binibigay natin is nicardipine, no? Pag mga hypertensive emergency, nagdi-drip na kami ng nicardipine drip para bumaba yung BP. So we have also non-dihydropyridine, the verapamil and diltiazem, no? That aims to decrease total peripheral resistance by decreasing contraction of vascular smooth muscles and cardiac muscles. Calcium channel blockers can be used in monotherapy or in combination, and it is well tolerated in renal failure. However, verapamil can cause constipation. It is contraindicated for heart failure and AV block. Dihydropyridine calcium channel blockers can cause dizziness, headache, and feeling of fatigue and edema. And nifedipine is known to cause gingival enlargement. No, this is a board exam question. No? So, paki-highlight na lang din. Dati naalala ko nagtanong sa amin na which of the following causes gingival enlargement? Nga, hindi ko alam. No? So, ayan. Pwedeng marami actually meron kang phenytoin, cyclosporin A. Pero nung time namin, yung nakalagay ni Fede, siya yung sagot. So we have renin-angiotensin-aldosterone system or RAAS. So for the brief summary on how RAAS works, no? So first, when the blood pressure falls, no, the kidney releases renin. Yeah, renin. Then renin converts angiotensinogen. Ayan. Ayan, angiotensinogen to angiotensin 1. Ay, lumagpas. Ayan. Oo nga, pag dito kaya, pag yung project kayo na dito. Sir, sir, pwede kaya yung akin, ang i-project mo na lang ito. Kaya. Kasi parang, or sige, ayan, okay na. Siguro wag lang masyadong gagalawin. Ayun naman nagpa-fluctuate. Ayan. Ayan. Hindi ko na lang gagalawin yung mouse ko. So, ayan. So, angiotensin 1, by the presence of angiotensin converting enzyme found in, it is found in the lungs, no? It converts angiotensin 1 to angiotensin 2. Presence of angiotensin 2 will react on the adrenal glands, no, found in the upper part of the kidney to produce aldosterone. So aldosterone will have an effect on the kidney to cause salt retention, therefore increasing the blood pressure. Pero, and angiotensin can also directly increase blood pressure. So yun yung nangyayari kaya tumataas yung BP via the renal angiotensin, renin-angiotensin aldosterone system. Okay? So yan, no? Therefore, we have these drugs, no? The ACE inhibitors. ACE inhibitors, pag may PRIL, alam nyo kahit yung med school nga ako, dito na ako, ano yung mga PRIL, mga ganyan. Pero kailangan tandaan. No? You have captopril, enalapril, lisinopril. Basta may PRIL, that is ACE inhibitor. So, this aims to decrease angiotensin 2, to decrease vasoconstriction. Ayan. So, ang mangyayari niyan, ay ito, baliktad yung X. Sorry. Dapat dito, nag-move yung X. Ayan. So, yung ACE inhibitor inhibits this enzyme, angiotensin converting enzyme, no? To inhibit the formation of angiotensin 2. So, pag decrease ang angiotensin 2, decrease ang vasoconstriction, therefore decrease ang total peripheral resistance. Okay? And pag decrease ang angiotensin 2, decrease ang aldosterone formation, decrease ang salt retention, therefore decrease ang blood volume, decrease ang cardiac output. Amazing, di ba? no? So relatively, it targets both cardiac output and cardiac output and total peripheral resistance. It is also renoprotective. Ibig sabihin, it is found that um, it is parang it protects the renal the kidneys, no? And it is the standard of care for patients following a myocardial infarction. Since ACE inhibitors achieve DP reduction, regression of LVH is left ventricular hyperplasia or paglaki ng left ventricle, and prevention of ventricular remodeling after MI. Kasi ang nangyayari, pag nag-MI, atake sa puso, nagkakaroon ng changes, no, sa ventricles, no, due to the attack. May part na namamatay yan, no, due to lack of oxygen supply. And this ACE inhibitor help to prevent that remodeling. And it is the first line of drug for treatment of heart failure. However, it can cause severe hypotension, acute renal failure, hyperkalemia, dry cough, angioedema, and it is known that teratogenic. Bawal siya sa pregnant. No? Hindi siya advised kahit antihypertensive. Kaya di ba yung cough, kaya minsan di ba may patients na, mayroong patient, tanungin kayo, inuubo po ako, uminom po ako ng ng enalapril. So, yan yun, no? Kasi ang ACE is found in the lungs, no? And nagkakaroon kasi ng increased level of gravity if there's if inhibit natin yung ACE, yung angiotensin converting enzyme. Therefore, pag nag-increase yung bradykinin, yung patient uubo ng uubo, no? Kaya pag yung patient inuubo na due to ACE inhibitor, we advise the patient to stop the medication. No? Okay ba? Okay ba? So, syempre, yan ang is to apply yung mga medication in the real setting kasi yung ngayon talagang missing, no, during pharmacy days. So, next is angiotensin 2 receptor blockers. So, dito naman yung mga sartan, no? Andisartan, irbesartan, losartan, olmesartan, telmisartan, and valsartan. So, like ACE inhibitors, no? Parehas lang sila ng mechanism ng ARB, no? ARB blocks the binding of angiotensin 2 to the angiotensin 2 receptor. So it acts as a competitive inhibitor, no? So ang mangyayari, hindi inhibit yung ACE, pero nag-block siya dun sa receptor ng angiotensin 2. No, yun ang ginagawa ng ARB. And it is an alternative to ACE inhibitor. Okay? It provides benefits similar to those of ACE inhibitors with patients with heart failure or CKD. No side effects, same lang din, no? However, it does not increase bradykinin levels. So, no cough. No? Walang cough sa ARB as compared sa ACE. Kasi di ba yung ACE inhibit, pag inhibit has a direct effect on bradykinin, no? Dito sa ARB, walang direct effect, no? Walang sa bradykinin. Therefore, walang coughing. Also, we have renin inhibitors. So, renin inhibitor like alisquirec or Tecturna, it is a selective renin inhibitor that lowers blood pressure as effectively as ARB, ACE, and thiazide. So it can be combined with other drugs, no? And however, it can cause diarrhea, cough, edema, and hyperkalemia. So relatively, there are different compelling indications of different drugs, no? Groups for heart failure. Specifically, no, meron tayong ACE, meron tayong diuretics, beta blockers, and ARBs. So different disease entities has different compelling different mixture, no, components of their management. No? For example, post-myocardial infarction. So meron tayo dapat beta blocker, ACE inhibitor, and aldosterone antagonist. Yung mga aldosterone antagonist, ito yung mga spironolactone. Hindi ko pala nasabi kanina. Aldosterone antagonist, yun yung mga potassium steroid. Like spironolactone and eplerenone, yung mga ganun. Baka balik ko kayo. Yan, mga non-pharmacologic management of hypertension. So, pwede kayo mag-advise weight reduction. Dok, baka naman may pwedeng ibang sa weight reduction. Ang hirap po nun. Exercise. Salt restriction, kasi for salt is water follows. No? Kaya pag iwasan yung mga aalat kasi magmamanas ka talaga dyan. No? Kasi ang maalat, pwede mo mag-cause ng retention ng water. Yan. Stress reduction, dash, eating plan, moderation alcohol intake, and if SDG can be maintained less than 140/90, treatment must be enforced. Pag mga patient naghihirap na makapag-ano dyan, talagang kailangan makikipag-bargain ka pa muna, no? Magagamit ba o hindi, no? So next, we have heart failure. Ituloy ko na, okay lang ba tapusin ko muna itong presentation nito? Then, saan tayo mag-break? Tapos mag-proceed tayo dun sa next topic. Okay lang. So next, we have heart failure. Heart failure is a complex clinical syndrome that can result from any cardiac disorder that impairs the ability of the ventricle to deliver adequate quantities of blood to the metabolizing tissues during normal activity at rest. So, normally, ang puso natin, tumitibok yan kahit nakaupo ka, no? Kahit hindi mo pilitin, dapat tumitibok yan ng pusa.
Ability of
ang heart failure, relatively, hindi niya kayang i-pump yung blood mo, no? Ang kailangan kasi syempre ang puso, marami pang marami nangangailangan ng organ ng dugo, no? And to spread, no, yung mga nutrients, yung mga drugs na kailangan, no, ng iba-ibang organ, kailangan i-pump niya, no? And if there's a inability, no, to deliver these adequate quantities of blood, so nagkakaroon yun yung heart failure. So it is described as a decreased cardiac output. So therefore, kung may heart failure, merong inadequate oxygen delivery in the body. So there are two classifications of heart failure. We have left heart failure, right? Left-sided yan, left-sided heart failure and right-sided heart failure. Pag sinabi namang left-sided heart failure, it occurs when the output of the left ventricle is less than the total volume of the blood received from the right side of the heart to the pulmonary circulation. Kasi normally, yung nasa left side of the heart, nanggagaling ang blood niyan sa lungs. No? Lungs papasok sa left atrium, bababa sa left ventricle. From left ventricle, aangat papuntang aorta palabas ng systemic circulation. So relatively ang patients noon, kung hindi siya makapasok effectively, nagkakaroon ng pulmonary edema kasi naiiwan yung tubig or blood sa baga. This niya, Rouse and cough. So yung mga patients na may heart failure kasi ng presentation, it can be left-sided heart failure. Pag right-sided heart failure naman, this occurs when the output of the right ventricle is less than the input of the systemic circulation. So, ang may problem naman dito is the right ventricle, no? So, ang nangyayari dyan, ibig sabihin, napupuno lang yung yung right ventricle, no? So, hindi makapasok effectively yung blood, no? So, nangyayari, di ba, ang dugo naman before mapunta sa puso, pabalik, no? Sa liver yan, di ba? From the liver, pabalik sa puso. Kaya nagkakaroon na peripheral edema, nagmamanas, splenomegaly and hepatomegaly, no? Lumalaki yung lapay at saka atay. Kaya naninilaw, no? So, yan naman ang heart failure, right-sided heart failure. So, makikita niyo sila yung mga manas. And the causes of heart failure is impaired contraction due to MI or myocardial infarction and arrhythmia and increased workload like hypertension. Kaya nga, as much as early as now, no, pag may mga patients na hypertensive, kung ano natin, mape-prevent natin as early as now, no, pwede kasi mag-hit na heart failure. Kasi ang nangyayari, bomba ng puso mo. No? So, nahihirapan siya, kaya pwede siyang masira. Parang ano lang, pag ginamit mo ng ginamit, no, mangyayari, masisita. So, that is hypertension causing, leading to heart failure. And the strategy for heart failure is to increase contractility by inotropics, decrease resistance by vasodilators, and to decrease fluid retention by the use of diuretics. So these are the drugs used for heart failure. We have inotropics, vasodilators, diuretics, and the others, examples, beta blockers, ACE inhibitors, and ARBs or angiotensin II receptor blockers. Inotropics, we have digoxin, aminone, dopamine, and dobutamine. So, digoxin is a glycoside from foxglove, no? Digitalis lanata, which inhibits the sodium-potassium ATPase pump, increases sodium, and therefore resulting to increase also calcium. So, pag mataas ang calcium, therefore magtataas ang contraction. So, as I recall, no, digoxin has a low therapeutic index. So, among the group of cardiac glycosides, no, digoxin is the prototype. So, yan yung mechanism niya, no, first. Saan yung first one natin? Ayan. So, yung digitalis, no, acts on the acts on the ATPase pump, no, making the potassium goes in and sodium goes out. But when the sodium increases outside the extracellular space, it increases the inflow and outflow of sodium and calcium as well, no? Ayan. Increase na yung calcium inside the cell, no? Tapos, calcium, it increases the extracellular calcium enters, no? And sensitized by the muscle of the heart, making the heart contracts. The side effect includes digitalis toxicity, especially if the patient is hypokalemic, no? Kaya relatively, if the patient is on digoxin, we should monitor for potassium. Kasi it can trigger arrhythmia, no? If the patient is taking digoxin, while the patient is hypokalemic. So these are the other signs, no, that can cause the side effects that are usual in patients taking digoxin. The treatment includes lidocaine or phenytoin, cholestyramine, and digoxin-specific pulp fragments antibodies to reverse this type of toxicity. So next we have inamrinone and milrinone. The mechanism includes inhibition of phosphodiesterase, increase CAMP, therefore increasing calcium, no, in the in the cell. So ito ginagamit ko sa mga specialized hospital, no, like mga heart center, no? Doon na lang yan available. And it is used for acute heart failure and severe exacerbation of chronic heart failure. So the difference between the two is that inamrinone is known for its toxicity, no, thrombocytopenia, liver enzyme, liver enzyme changes and arrhythmias. It can be used liver toxicity and bone toxicity as compared to inamrinone. That's why hindi na siya binibigay yung inamrinone kahit sa US. Dopamine, it is used in acute heart failure, especially if there's a need to raise blood pressure. No? Sa mga decompensated heart failure, pag yung mga patient na ang baba-baba ng BP, pero kasi gusto natin magpaihi, no? Kasi usually mga heart failure, punong-puno ng tubig yan, no? We need to diurese the patient and we use dopamine to increase the BP for us to permit diuresis. Dobutamine, ito yung mga second line na mga pressors that we can use for decompensated heart failure. Again, it can be given together with dopamine. And dobutamine causes less tachycardia as compared to Doc, is milrinone same as amrinone. Magkakamag-anak naman yan sila. Amrinone, inamrinone, milrinone. Pero yung milrinone na lang kasi yung alam kong available ngayon. No, kasi yung inamrinone, baka yung amrinone is inamrinone yan, ma'am. Inamrinone. Sorry, baka typographical error lang. Amrinone lang doon nakalagay. Tumalaw. Okay, thank you. Vasodilators, like hydralazine and nitrates, no, na-discuss natin kanina. And these drugs reduce the preload. So yung preload, it is the stretch. Initial stretch of cardiac myocyte. So para hindi siya masyadong stretch during contraction, prior to contraction, no? So vasodilator and reduction of afterload. So yung afterload naman is the force, no? Force of for the heart to eject blood to the out of the heart, no? That is afterload. So ang ano lang natin is not to make the heart do forceful activities, no? Gusto natin mag-contraction ng maayos pero hindi in a parang in a ano lang, in a lighter way lang, no? Kaya tayo bibigay ng vasodilators. Next is diuretics kasi nga we need to reduce the salt and water retention. So we use loop diuretics and aldosterone antagonists like spironolactone and eplerenone. And also beta blockers except pag symptomatic, congested pa yung patient, we are not using beta blockers, no? But for maintenance of heart failure, we can give beta blockers. Especially yung tatlong sinabi ko kanina, carvedilol, bisoprolol, and metoprolol succinate. Sila lang yung may beta blocker na na-study for heart failure. Okay? Pero kung congested ang patient, stop. ACE inhibitors and ARBs also can be used. And angiotensin receptor replacing inhibitor ARB. So ito yun yung sa cubital valsartan. Familiar kayo dito? Narinig nyo na yung Entresto. So, Entresto or Bimada, Bymada. Yun yung generic. It is under Novartis, no? So, it is a neprilysin inhibitor. So, neprilysin is an enzyme that breaks down natriuretic peptides, preventing them from doing their job. So, sacubitril is a neprilysin inhibitor that inhibits this neprilysin, and valsartan blocks the angiotensin II receptor. And combining the two, no, has a good effect, no, based on the Pioneer HF study that special on patients with decompensated heart failure. Actually, may just to share, no, I have this patient, no, dumating sa akin, right-sided heart failure siya, alcoholic, 34-year-old, manasama na siya, no, naninilaw. That time, yung patient na yun, nagmamakaawa siya sa akin, naka-wheelchair na siya. Tapos sabi niya, gusto niya pa daw mabuhay. Kasi nga daw, may anak pa daw siyang bata. Pero wheelchair born na siya, tapos parang hingal na hingal siya. That time, hindi ko siya in-admit, pero bin-advise ko siyang uminom nito sa cubital valsartan. Then weeks after, no, mayroon, gulat ako, may yung junior ko that time, no, binigyan niya ako ng, sabi, Doc, may nagbigay po sa inyo ng donut. Hinahanap niya po kayo, kaso hindi ko po kayo makontak. So, sino kaya yan? Tapos parang sabi ko, okay. So, sumunod na araw, meron na namang donut. No? Meron na namang donut. Tapos, that time, may tumatawag sa akin. Sabi niya, Doc Advento, Doc Advento. So, Doc, ito na po ako ngayon, kaya ko na po ulit maglakad. Hindi na siya manas, payat na siya, nakakaakyat na siya ng hagdan. Relatively yung pictures niya, yung symptoms niya, wala na. So, I have this, and those are isa lang siya sa mga success story ko with using this drug. However, napakamahal pa niya, no? Dahil under patent pa siya ng Novartis, no? So, pag nakita niyo siya sa mga community pharmacy ninyo, pag tanong niyo kung Entresto. However, it is contraindicated for patients with hyperkalemia and increased creatinine. No, usually, pag gagamitin siya for patients with CKD, that sobrang amazing yan. So, management of heart failure and diuretics. So, in the furosemide, inotropes, and vasodilators. And also, we use vasopressin antagonists. These drugs are used for heart failure with delusional hyponatremia. Kasi, so sobrang manas na nila, nag-hyponatremia na sila, sabihin delusional, dahil sa tubig, di ba pag kanyari, isang balde, tapos kumamit ka ng, kunyari, sabon joy, hindi yun sasabon, di ba? Unlike kung konti lang yung tubig, parang gano'n. So, delusional hyponatremia, normal naman talaga yung sodium niya, pero dahil nga marami yung tubig, nagiging delusional, nagiging low ang sodium. So, to address that, we use vasopressin antagonists like conivaptan and tolvaptan. So, ang nangyayari dito is that it has a lower, ang goal nito is to increase sodium, no? While we do diuresis na. Or pwedeng kumbaga, it can aid diuresis without affecting the sodium component. Ayan, pag acute heart failure, contraindicated ang beta blocker. Okay? Pero pag chronic HF, hindi masyadong kita, Sorry. Iyan natin, lakihan natin. Ayan. Mas dikit-dikit kasi eh. Pero ayan, at least medyo basa naman, no? So, there are different classification of heart failure. Yung chronic heart failure, ibig sabihin, matagal na silang heart failure, no? So, pag relatively, pag class D na siya, doon kasi mayroong structural problem na yung puso. So, relatively, pag naglakad yan sila, may hingal na talaga. And yun yung significant na classification. No? That we need to give more drugs like aldosterone antagonist, digoxin kung may atrial fibrillation, yan, no? ARNI, hydralazine or nitrogen if indicated. Pero pag meron ng severe symptoms kahit nakaupo, no? May mga patient na ganyan na yun, hapon na sila kahit nakaupo lang. So it requires maximal medical therapy. Kung hindi, or kung kaya pa mag-transplant, pwedeng magpa-renal transplant or cardiac transplant. So last of this topic is ischemic heart disease. Ischemic heart disease is the form of heart disease with primary manifestation that result from myocardial ischemia due to atherosclerotic coronary artery disease. So, ano nangyayari, no? Nagkakaroon ng bara dahil sa taba, dahil sa cholesterol. And pag napuno yan, ibig sabihin, barado na yung puso. Pag barado na yung puso, wala nang dadali doon, di ba? Kailangan natin ng oxygen to supply the different parts of the organs. Yan yan. Kaya nag-a-atake sa puso. Ang puso, kailangan niya ng oxygen for it to thrive or to survive. Pagka walang oxygen na nagdali dyan, yun yung atake sa puso. Yung muscle na yun can die, no? So, walang perfusion doon kaya nakakakos ng sakit ng libog ko. Pwede nga sa hospital. Ganun yan. Okay? So, yun yung nangyayari. Ang saya pag nalalaman mo kung paano siya nag-work. Coronary artery disease refers to the number of diseases other than atherosclerosis causing an narrowing of the major epicardial coronary artery. And ischemic heart disease can present as acute MI or myocardial infarction, as stable angina, chronic stable angina, or variant. So, paano ba sila yung iba-iba? Angina pectoris is the common form of IHE. So, relatively, ang nangyayari lang, kaya sumasakit ang dibdib kasi less ang oxygen na dumadali doon. Okay? So, applied to varying forms of transient chest discomfort that are attributed to insufficient myocardial oxygen. Kaya kailangan maganda ang lari ng dugo para yung oxygen masusupply na doon sa end organ, particularly the heart. So there are different types, no? Number one, we have stable angina. It is the most common form. It is triggered during exertion, no? Nabuhat ng mabigat. Meron minsan, di ba sa mga teleserye, wala. Yan. Mas gano'n na, di ba? Yan. And meron talaga mga patients gano'n, no? Nakarelate ka ba? Nakarelate nyo, no? So, baka sa inyo may mga nakaka-relate din, no? So, yung mga gano'n, no? Or minsan, yan, naku, kumain lang daw ng maraming ganyan, na sa puso, mga ganyan. Mga ganyan, sumakit yung dibdib, ganyan. So, yan, precipitates as chest discomfort. Usually, it relieves with rest, nitroglycerin, or both. Ang remedy dyan natin, pwede tayo mag-supply ng oxygen or decrease ang cardiac work or rest, no? Para hindi masyadong nagpapump yung heart. Next is unstable or crescent angina. So, the patient experiences rest angina. So, kahit nagre-rest siya, sumasakit ang dibdib niya, no? Severe new onset angina, increasing angina, decreased response to rest and nitroglycerin. So, ginawa mo na lahat, no? Nag-rest na, nahiga na, tapos nagbigay ka na ng oxygen, nagbigay ka na ng nitrates, wala pa rin. So, that is unstable or crescendo angina, no? And decreased oxygen demand with this type of patient. So unstable unstable angina is an acute coronary syndrome na yan, no? Pwede na siyang i-consider as MI. And usually yung tinatawag namin STEMI, no? Ang pag-STEMI, ibig sabihin, yung ECG niya hindi nagko-conform o parang hindi niya nami-meet yung criteria pero meron siya, no? Parang ganun. Next is Prince metal or vasospastic or variant angina. Usually occurs at rest, no? Rather than exertional or emotional stress due to coronary artery spasm. Ito yung mga usually common sa mga active athletes, no? Minsan, nakakaramdam sila ng sakit ng dibdib, ganyan. Pero relatively, sila young, physically fit, no? It can be metal. So due to coronary artery spasm and the drug of choice in this type of angina is with the use of calcium channel blockers. So our strategy is to increase the delivery with the use of vasodilators through nitrates and calcium channel blockers, no? And to decrease oxygen demand. Kasi pag ang heart nagpa-pump siya ng mabilis, mataas ang demand niya. So kailangan mo siyang pabagalin yung demand, no? Pabagalin ng heart rate para mag-decrease ang demand. And we can do this by using beta blockers and calcium channel blockers. And there are different drugs for angina. We have nitrates, calcium channel blockers, beta blockers, and miscellaneous like ranolazine. Nitrates, so we can use nitroglycerin via sublingual, spray, transdermal patch, oral, IV infusion. So mga internship nyo pwede yung hanapin kung merong available. So it can be in the form of isosorbide nitrate. So ito yung binibigay natin na sa mga binibigay via sublingual route, no? Or mononitrate. Yung mononitrate, it is taken via oral route. Isordil is ISDN. ISMN is yung IS, hindi ko lang alam yung brand ng ano ba yun? ISO something din. Yan, yung yung mononitrate, oral yung iniinom, no? So usually yung mononitrate, yun yung ginagawa natin yung maintenance, no? Endure, yan. Endure ang ISMN. Okay. Nitrates is converted to nitric oxide to induce CGMP, causes smooth muscle relaxation, causing vasodilation. So however, it can cause orthostatic hypotension, tachycardia, and throbbing headache, and tolerance, no? Next, we have calcium channel blockers. So this calcium channel blockers includes nifedipine, amlodipine, and nicardipine, diltiazem, and verapamil. So this class or this group in general is the drug of choice for Prince metal angina. However, it can cause cardiac arrest, bradycardia, AV block, and heart failure. No, kaya caution din sa paggamit ng calcium channel blockers. And dibodipine, dito ko na lang yung siningit, no? It is the one selective for cerebral blood vessels. Binibigay naman yan for patients with hemorrhagic stroke, no? Yung kung may pumutok na ugat, pag may pumutok na ugat sa utak, no? So, yung dibodipine ang ginagamit, binibigay dyan. Kasi selective siya for cerebral blood vessels. Pero sinama ko lang siya dyan. Pero hindi siya pang IHD. Para lang nandyan na lang din. Next, we have beta blockers. We have propranolol, metoprolol, and the others, no? So, Like in hypertension, it decreases heart rate, beating, and contraction to decrease oxygen demand. So it is used for the treatment of stable angina. And kasi pag heart failure and yung mga IHP, MI, the heart rate target natin is 50 to 70. No more than that, no? Kung kunyari, ano siya, atake sa puso, MI, no? Tapos ang heart rate niya is nasa 90 pa rin. It's either i-increase namin yung ano niya, beta blocker na, i-increase namin yung dose ng beta blocker niya, no? Or papalitan namin ng ibang pampadikis ng heart rate. Ganun siya. Kasi hindi siya pwedeng pagod yung heart. Dapat adequate lang yung pump niya para hindi siya mapagod. Ayan, yung mga newer drug, no? We have ranolazine. So ranolazine is, it acts in the reducing, by reducing the late sodium current channel, no? That facilitate calcium entry via the sodium calcium exchanger, decreasing the intracellular calcium. So ito parang medyo similar dun sa mechanism of action ng digoxin, no? And it is ranolazine is an approved anti-anginal drug in the US. Ayaw. So meron pa tayong mga metabolic modulators like trimetazidine. It is a PFOX inhibitor which partially inhibit the fatty acid oxidation pathway in the myocardium, no? So in ischemic myocardium, metabolism shifts to oxidation of fatty acids which causes the oxygen requirement for ATP produced to increase. Kaya gusto natin itigil yung fatty acid metabolism doon. However, trimetazidine is not used or not approved, no, in the management of ischemic heart disease. Pero pag mga chest pain, binibigay yan dito sa Philippines, no? Usually at 35 BID. Trimetazidine. Pagka may check nyo yung mga gamot ng mga magulang para yung PFOX inhibitor yun, no, gano'n, or mga lolo't lola nyo, baka ma-encounter nyo rin yung mga meds. So next we have bradycardic drugs, no, like ivabradine. So ivabradine is a selective IF sodium channel blocker that reduces the cardiac rate, no, but has no significant hemodynamic effect. So wala siyang effect sa BP, no, only in the heart rate only, no, and they're relatively advantageous siya when managing patients with high heart rate. So that's the end of our second lecture. So we can have 10-minute break na lang siguro. Okay lang. Then we'll proceed with the next topic. Are there any questions? Wala naman, malinaw naman. So hopefully may mga na-recruit ako mag-med dito. Joke lang. So then technically, no, before talaga, ako gusto ko talaga mag-cardio before nung ako. Pero internal medicine, I'm an internist. Oo. Pero yun nga, pagka wala rin yun, baka mag-fellowship training pa ako. So hindi ko lang katapusan na talaga to, guys. No? So yun.
Sir, nakamute ka po ba?
Okay, we'll proceed with the last part of anti-cardiovascular drugs. We have anti-arrhythmics. So as a short overview no, of the conduction system of the heart, the heart is composed of four main structures. We have, ay hindi pa pala ako, wala pa akong sound. Ayan, may sound na. Hello? Ayan. For structure, main structure, we have the sinoatrial node. No? It is the main pacemaker of the heart. It initiates 60 to 100 beats per minute, and it is responsible for the atrial contraction. And we have the AV node. So the one with the yellow, ano, this one. Ayan. So ito yung AV node, no? So then you check the transmission travels through the network of fibers, no? To the bundle of leaves, and lastly the Purkinje fibers, where it is responsible for where these fibers are responsible for the ventricular contraction. So ito, no? So the basis for the antiarrhythmics is through the myocardial action potential. So there are different phases. We have the phase 0. Yeah. So called the upstroke, no? Phase 0. So we have which is the rapid depolarization. We have the phase 1, which is the early rapid repolarization. Then phase 2 is the plateau. Phase 3 is the final rapid depolarization, and lastly, the slow depolarization. So I will take you through the myocardial action potential, no? Para mas maintindihan niyo siya. Hopefully, maging successful ako na ma-explain siya. So, the transmembrane potential is of the cardiac cells are determined by the concentration of sodium, no, chiefly the sodium, potassium, calcium, and chloride. The permeability of the membrane to these ions varies. It varies, no, and these water soluble ions cannot really diffuse to the lipid cell membrane that it requires aqueous channels for diffusion. So normally, our lipid bilayer, this membrane, has a negative membrane potential, no? Negative around 85 to 90 millivolts. Kaya siya, yan, negative yan, negative. So this is the resting membrane potential, no? And at this level, sodium, so it has a fast channel, no? Called the sodium channel enter the cell. Yeah, sodium channel enter the cell through its fast channel, no? Nakapasok siya. And it uses also the slow channel of the calcium, no? For the calcium to enter also inside the cell. So, the upstroke, yung ito, the phase 0, yan, yung pag-angat na yan, kasi pumasok na yung sodium and calcium. So, there's an increased sodium and calcium conductance through the fast sodium channel and slow calcium channel. And usually, yung sodium, opposite ang direction niyan pag sa potassium, no? So potassium goes out. Kaya makikita nyo dito, no? Pag pumapasok ng sodium, pag mababa ang sodium and calcium niya papasok. Pero yung calcium lalabas. No? So there's an increased sodium and calcium conductance and decreased calcium and decreased potassium conductance in most part of the heart, and sodium channel predominates in this action potential, and therefore yung increase in sodium and calcium conductance is shown as an upstroke, no? Pumapas. So it become more positive, no? Lagpas pa ng 0 millivolt due to sodium and potassium upstroke. Next, when the threshold is reached, sodium channel was inactivated. So at this point, no, may inactivate na yung sodium channel and only leaving leaving the cell, no? Therefore causing initial repolarization. Kaya ang mangyayari, bababa siya ng konti, no? Kasi ang nangyayari, tumigil na si sodium, no, na pumasok. So nangyayari, mas further tumataas ang pag-alis ng potassium. So mas nag-negative siya, kaya nagkaroon ng phase 1 or initial repolarization, no? Early initial repolarization. Then calcium balancing the influx, no? So kung may so yung calcium, di ba tumigil yung sodium, pero yung calcium continuous pa rin siya, no? So there's a balance calcium influx and potassium efflux. Yung efflux palabas, so yung potassium palabas, yung calcium paloob pa rin, pero slow channel siya, therefore forming a plateau. Ay, bakit ganun? Ayan. So, di ba? So, dito sa phase 2, balance ang calcium, slow calcium influx, and potassium efflux. Therefore, nagpa-flatten, almost flatten siya. So, this part is called the plateau or flat, almost flat, di ba? Then, at the end of the plateau, calcium, so at certain level, calcium influx closes, no? Saan na ba yung cursor na yun? At this point, no, calcium influx closes and calcium efflux predominates. So, mas dumadami yung calcium efflux. Therefore, there's a late phase repolarization. And lastly, when the level of baseline or resting membrane potential was reached, it becomes at phase 4 again. And the cycle continues. So yun lang yung ano nito, no? And this is the basis of different anti-arrhythmic drugs, no? So it targets different channel, calcium channel, sodium channel, potassium channel, no? So important na alam na lang kung how this drug works. Malinaw? So nakita nyo, no? Tataas na si sodium, calcium. Pag na-reach yung sodium, balance calcium and potassium, influx and efflux. Then at certain level, calcium stops, then potassium predominates, kaya babagsak. So, dito naman sa sinoatrial node, different naman siya, no? So relatively, the sinoatrial potential has a resting potential less negative, no, at around 60 lang, no? Kaya siya ganito lang yung itsura. So relatively sa sinoatrial node, so yun ang AV node in general. So mas mababa siya. Yung buong myocardium, mas mababa yung resting potential. Pero yung sinoatrial node, less than negative 60 lang. And at this space, kaya wala tayong upstroke is because at this level, hindi na-activate yung sodium upstroke. No? So every time the action potential becomes less negative than 55, no? Sodium channel gets deactivated, hence calcium channel contribute more for the upstroke. So ito lang yung upstroke na. So we eliminate 1, 2, so meron lang is 4, 0, and 3. So yung pag-akyat na yan is due to calcium lang influx. So we have phase 0 depolarization to calcium in conductance through the L-type calcium channels. Then the long-lasting calcium channels in the form of ICA via L-type current, no? It further it continues to increase, no, to ascend, and when the threshold reaches to its maximum, potassium efflux predominates. So wala na ditong kagaya nung kanina na meron pang plateau, no? So it proceeds with the repolarization phase agad. So from 0, mag-repolarization phase na siya agad at phase 3, no? Making it more negative again. Hanggang ma-reach niya ulit yung final resting membrane potential, kaya siya medyo paangat kasi meron tayong mga at the sinoatrial node, leaky ang mga cell dahil sa gap junction. So ano nangyayari? May mga nag-leak na mga sodium and calcium, therefore responsible to the slight upstroke, no, of the resting membrane potential. So kung mapapansin niyo yung myocardial infarct, myocardial muscle kanina, straight lang yung resting membrane potential. Dito, dahil nga leaky yung junction ng cells dito sa sinoatrial node, kaya medyo nag-leak din yung electrolytes. Therefore, nakita natin na may upstroke, slight upstroke in the RMP or resting membrane potential. So hopefully naintindihan niyo yung graph na yan kasi dyan yung basis ng mga meds na. So ECG, no? So ito yung mga nakikita natin, no, yung mga it is the impulse of the heart, no? Electrical impulse of the heart. So it forms a wave, no, upon attachment of electrocardiography in the heart. No? And there are 5 important waves, the PQRST. So P wave represents atrial depolarization, no? And QRS represents the ventricular depolarization, while P wave is the ventricular repolarization. So nagtataka kayo, bakit walang atrial repolarization? No? So it is somewhere here, no? Yan. Somewhere here, pero dahil nga somewhere here, pero kasi yung atrial repolarization is parang na-bury na kasi atrial repolarization and ventricular depolarization occurs at the same time. No? Kaya na-bury na siya ng ang ventricular depolarization creates a larger weight than atrial repolarization. Kaya wala tayong atrial repolarization. Okay? So we have P wave, QRS, and P. Amazing, di ba? Yung iba kasi nagpapatato kasi mali, no? Sayang. So arrhythmias, or also known as dysrhythmias, consists of cardiac depolarization that deviate from the normal sinus rhythm. So yung normal sinus rhythm natin is this one, no? We have the PQRS, and anything na different dyan, that is arrhythmia. Okay? May mawala lang dyan isa dyan. Arrhythmia yan. Okay? So it includes abnormalities of the impulse formation and conduction disturbances. And these are the factors that exacerbate arrhythmias. We have ischemia, hypoxia. Ischemia is yung for example, decrease in oxygen supply, no? As in the case of myocardial infarction, no? Hypoxia, acidosis and alkalosis, electrolyte imbalances, catecholamine exposure, autonomic influences, drug toxicity, overstretching of cardiac fibers, and scarred or otherwise disease tissues. And there are different classification, no? We have supraventricular arrhythmias. So it is due to the enhanced automaticity of the ST node and the conduction. Ito too much for you to know na yung mga ganyan, no? Basta supraventricular, above the ventricles, lang yung sabihin. Yun yung arrhythmia occurring above the ventricles. And we also have ventricular arrhythmias, where there is a ectopic pacemaker that triggers a ventricular contraction before a SA node fires. Kasi technically, ang nagsasend ng signal for a ventricle to contract is the SA node, no? Following an AV node. And sometimes, pag ventricular arrhythmia, there are some place in the heart, no, that also sends signals. Medyo may sumasabat ba? So yung sumasabat, iba yung lumalabas na NP. Nababago tuloy yung rating, yung sabay na electricity sa heart. So that is ventricular arrhythmia. Actually, nung dati nung sugot ako, hindi ko talaga siya nag-gets. Pero I'm very happy na yung share ko siya. And anti-arrhythmic drugs are classified based on Vaughan-Williams classification of anti-arrhythmic drugs. Currently, meron new update kasi, pero hindi ko na siya malaki lahat kasi ang dami. Parang ngayon, there are 7 classification. Pero pinalo ko na lang yung nasa book na for now. Kasi ngayon, kakalabas lang parang nainit-init pa, no? Meron ng 7 classification of anti-arrhythmic drugs. But nilagay ko na lang si class 0 kasi siya yung nakabago. Pero currently sa textbook nyo, di ba ang ano niya is 16th edition, 15th edition na Katsung. So, ang nakalagay lang is class 1 to 4. Pero ngayon, meron siyang class, hanggang class 7. So we have class 0, we have drugs that are acting on the atrial autonomicity. So it includes ivabradine. Sodium channel blocking drugs like sodium channel blocking drugs, beta blocking drugs, potassium channel blocker, and calcium channel blocking drugs. So class 1, we have sodium channel blockers. So, additional transiranolazine, no, meron na tayong 1D. Nilagay ko na lang din para for the benefit of you, no? So, currently, na-classify na siya as sodium channel 1D blocker. So, we have A, which is disopyramine, pinidine, and procainamide. B, we have tocainamide, phenytoin, lidocaine, and mexilidine. C, we have lignanide, aconite, propaquinone, and morizine. And lastly, we have the newest classification, newest in the group, no, si ranolazine. No? Ranolazine is classified under 1. So mamaya natin siya i-discuss. Beta blockers, no, like propranolol and smolonilis butylol, we discussed earlier. We have class 3, like potassium channel blockers, ibipilide, sotalol, betilium, amiodarone, and dofetilide. So currently, this betilium is not available in the market, no? But it is used previously for ventricular fibrillation. And lastly, yung class 4, yung calcium channel blocker, but it is exclusive to the non-dihydropyridine. Hindi kasama dito yung amlodipine, elodipine, only diltiazem and pirapat. So let's discuss them one by one. No? Sodium channel blocking agents, or class 1, is the oldest group of anti-arrhythmic drugs, and they are still widely used. These are drugs with local anesthetic action that block sodium channel and reduce sodium current. And subclasses has effects on the action potential duration and kinetics of sodium channel blocking. So kung maaalala nyo, no, this is the black one is the appearance of the action potential. No? And relatively, different drug classes have different effect on the action potential of the myocardial action potential. No? So the red one is the red is 1A. The green one, the blue one is 1B, and the green one is 1C. So yan yung effect ng different sodium channels, no? So makikita nyo 1A. So 1A daw has a moderate channel blocking, which increases the ERP or the resting potential. So it binds and blocks the fast sodium channels that are responsible for the rapid depolarization of fast response cardiac action potential. Kung makikita nyo, mas lumiliit siya, no? Kasi di ba, kung naaalala nyo, di ba, sodium is responsible for the upstroke of the myocardium. Di ba? So what like lidocaine, so kaya di ba lidocaine anti-anesthetic siya, but also it is an anti-arrhythmic that can decrease the ERP, but it has a weaker sodium channel blocking. So makikita niyo mas mataas pa siya. And lastly, we have ito yung hindi pala, mataas pa siya. And lastly, we have the stronger sodium channel blocking, the classic 1C, no? So makikita niyo mas mababa yung upstroke niya, no, as compared sa iba. Kasi it has a stronger sodium channel blocking, no, than the rest of the group. Procainamide, it is used for sustained ventricular arrhythmias associated with acute MI. However, it can cause syndrome resembling lupus erythematosus. It is the drug of choice, a drug of second and third choice for sustained ventricular arrhythmias. Next, we have quinidine. It is used for the maintenance of sinus rhythm in patients with flutter or atrial fibrillation. So mamaya papakita ko yung picture ng flutter at saka atrial fibrillation. No? And it is used for the prevention of recurrence of ventricular tachycardia and ventricular fibrillation. It is known to cause synchronism. It is a constellation of headache, dizziness, tinnitus, and other constitutional symptoms, no? And synchronism kasi galing nga siya sa synchro na part, no? Kaya synchronism. Disopyramide is used for the treatment of ventricular arrhythmias. However, it is notorious to cause urinary retention, dry mouth, blurred vision, constipation, and worsening of pre-existing glaucoma. However, this is contraindicated with patients with heart failure. Pag meron na siyang side effects na ganito, it is warranted that the drug must be discontinued. No? Lidocaine no, is used for as a agent of choice for termination of ventricular tachycardia and prevention of ventricular fibrillation after cardioversion of in the setting of acute ischemia. So ito yung mismong anesthesia na yung ginagamit na pantuli, no? Dati nun may patient ako talagang kinakabahan talaga ako baka mamay mag-arrhythmia. Kasi talagang sabi ko, shit, baka mag-arrhythmia to, no? So naka-stand sabi ko, pwede bang bingin lidocaine? Sabi ng nurse, ha? Bakit hingin ng lidocaine? Hindi ka naman mag-anesthesia do. Sabi, hindi, para siya sa patient ko na possible mag-arrhythmia. And it can be given as a drip, no? Pag mga patients na nag-arrhythmia. Pero depende sa arrhythmia, guys. Hindi sa lahat ng arrhythmia yan. However, ito yung mga pwede side effect ng lidocaine. No? It can cause paresthesia, tremor, nausea, lightheadedness, hearing, slurred speech, and convulsions. No? Because it is also an anesthetic agent. Placanine is a drug for patients with otherwise normal hearts who have supraventricular arrhythmias. However, it is not used nowadays, but it is seen to be effective for suppressing premature ventricular contraction. Yung premature ventricular contraction, bigla na lang siyang susulpot na hindi naman siya magtutuloy. Yun yung premature ventricular contraction. Medyo technical na pag diniscuss ko kaya, pero basta hindi siya masyadong ginagawa. Propafenone, so this is used also for supraventricular arrhythmias. However, it is discontinued due to its adverse side effect of letalities and constipation. Merisicin, it is used for ventricular tachycardia, arrhythmias. However, it can cause dizziness and nausea in patients. Beta blockers, it is a group 2 anti-arrhythmic drug since it prolongs the cardiac action potential. And esmolol is the one mostly used, no? Because it is a short-acting beta blocker, no, for intraoperative and other acute arrhythmias. So usually yung esmolol is included in the e-card. So pag nag-hospital na kayo, check nyo kung, kunyari, mabigla kayo maging emergency pharmacy, sa ER pharmacy, check nyo, doc, sa pharmacist nyo, nag-e-card po ba dito? Kasi usually ang ER pharmacy, nagpupuno nun, no? Kung ano yung mga nakalagay sa e-card, emergency card. So, dapat may mga diazepam yan, epinephrine, blah, blah, blah. And usually, isa sa mga dapat laman nun is potassium channel blocker. These drugs prolong the action potential usually by blocking the potassium channel in the cardiac muscle. However, this is it is known to cause action potential prolongation. However, there's a risk of reverse use dependence. So, this is an effect where the efficacy of the drug is reduced after repeated use of the tissue. So, kumbaga, parang you can prolong it once but not on a maintenance, no? Kasi nangyayari, kahit anong bigay mo, pag on the long run, hindi siya mag-i-effect. And it is also has a risk of having torsades default. Mamaya iano pa yan, ipapakita natin. Ayan, so may mga sample picture na ako para mas ma-visualize nyo. Kasi ito yung mga most common, like amiodarone. So amiodarone is a treatment for serious ventricular arrhythmias. It is highly effective for the treatment of supraventricular arrhythmias such as atrial fibrillation. Pero hindi pa rin siya ang first line. No? The first line is amiodarone for SVT. So supraventricular tachycardia. Pero yung atrial fibrillation na persistent, no, you can give amiodarone. Via drip or initially via bolus and via drip. So ano ba yung sinasabing atrial fibrillation? Yung atrial fibrillation, kung makikita nyo yung ECG niya, di ba ito yung normal rhythm, makikita nyo patay-patay siya. Pero yung atrial fibrillation, hindi siya regular. No? Biglang mahaba, tapos biglang dinipis, tapos pacing na naman, tapos mahaba na naman yung distance. Ang tunog na dug, 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 dug. Kumbaga, ano siya, may irregular yung ano niya, yung direct current niya, no? So, yan yung atrial fibrillation. Okay? So, usually, pag new onset na atrial fibrillation, we can give amiodarone. Amazing, di ba? Tapos, after niya, makikita nyo na lang, yun sa monitor, di ba, ganyan siya, magiging ganito. Amazing.
Huwag na.
Di ba? So, ang daming
Wag na.
ano talaga, no?
Ito na all bracelet.
Pero mahirap. Kasi kumbaga, it's matter of life and death. Pag hindi ka talaga dapat yung focus mo
Manisin mo
talaga.
na.
Kahit inaantok ka na, no? Pag sa emergency
Mag-enjoy
room.
ka din.
Ang mga sakit niyan sila, darating sila mga alas sa madaling araw. Yung talagang inaantok ka na.
Wala
Yun
mang.
talaga yung
Ay, gusto mo pala apat. Okay.
However, no?
Wag na.
Side effect include symptomatic bradycardia
Bilis
and
naman.
heart block in patients with pre-existing sinus or AD pulmonary toxicity, hepatitis, dermatitis, and hyperthyroidism. Kasi yung amiodarone has an iodine containing siya. Kaya pwedeng siya mag-trigger ng hypo or hyperthyroidism. Kaya dapat yan, monitor when administering
Speaking na.
yung mga ganyan. Meron kami yung patient before, yung parang, alam mo yung parang bigla na lang may gumagalaw ng sweat, ng ano lang. Yung
Ano
parang
nililinis?
kinokontrol,
Nilalapan yan.
nire-regulate yan ng nurse usually. Tapos mamaya-maya, parang siya nagpa-fast trip na parang pinapainit.
Picking na, picking
lang
na.
namin yung patient hypertensive na, pababa na yung BP, ganyan. No? So para talagang minsan, talaga may mga multo talagang hindi natin explain lalo na sa hospital. Actually, mayroon ng kwento nga, just to share lang na guys, sa mga TFC subscribers, kwento ko lang. Hindi ko mapigilan eh. So before, sa hospital kung saan ako nag-flirt, dalawa lang ang fate ng mga patients, no?
Bastos.
It's either sa ICU, no? Intensive heart
Bastos.
kasi di makakakita sila ng fate na madre walang mukha
Bastos.
or batang
Alam mo.
tumatakbo. Pink na madre, tatlong madre na walang mukha. At saka, tawag dito, secret, syempre hindi ko i-disclose. Tapos, or matang
Feel ko may kasama tayo dito.
So, pag, kung makita mo yung tatlong madre na
So,
walang mukha,
anim pa lang yung di nagla-lunch.
ibig sabihin magre-recover ka.
Dalawa na lang.
Naka-unmute po kayo.
Tingnan mo kung may kasama tayo.
May naka-unmute po. May naka-unmute. Okay. So, pagka nakita mo yan, makaka-recover. Pero pag nakita mo yung batang tumatakbo, mamamatay po. Sasabihin niya, merong patient nakatulog minsan. Sabi niya, kausap ko yung madre walang mukha. Hindi naman nila alam. so tayo nasaan ka na kanan kaliwa. Just share ko lang. Pero well, hindi wala naman ako nakita. Pero dati meron nun sa amin construction worker, gusto niya i-save yung bata. And that time, ginagawa yung elevator, nalaglag siya sa, yung construction worker nalaglag sa elevator. Tapos ang niya, gusto niya daw kasi i-save yung bata, tumatakbo. Ha? Paano na? Hindi, nung nag-design na siya, may nakita siyang bata tumatakbo, nung gusto niya i-save. Kasi tumalon ng elevator. Anong nangyari? Siya ay nalaglag. At third floor yun. Hindi ko na maalala eh. Ano ba, nabuhay ba siya ulit? So, ano, out of, ano yan, just to, ano lang, to break the bubble. Alam ko, yung mga students ko usually, ano, interested sa mga ganyan, horror story, ghost
Make
story,
sure nakita ka ng
no, sa mga
Jupiter.
TikTok, no, ano, mga ganyan, di ba? Ayun. So, kasi ang buhay sa ano, minsan nagtatakotan na lang kayo, ganyan, sa hospital. Minsan, ha? Hindi naman ako nakakakita, pero yung iba nakakakita. Meron something parang,
May
meron
bar
daw
dito.
upper pag bangon, parang wala naman daw.
Ayaw ma-bar?
Pero meron ano sa paa, ewan ko.
May
Basta ako pag
solaris
inaantok
akong
ko,
dala.
matutulog ako.
Oo.
Pagalingan lang yan.
Pinin ko na yung may
Discarded.
namatay.
Ah, sa mga nurse, well, pwede rin
pa-drop
naman,
ko.
pero so far
Doon
wala
sa'yo?
naman nagparamdam sa akin. Pero pag gano'n, pagdasal mo na lang siya. Pero sa dami talaga ng mga patient na, yan nga, yung mga na-experience ko before, ano, tingin ko naman, grabe talaga. Talagang,
Ba't niyo ako
hindi ko na
tinatawag?
lang ma-explain.
Nalot mo na ba
Minsan
dito?
talaga yung sasagarin ka talaga sa pagod dahil yung mga patients with the niya. Kasi hindi ka talaga patutulogin talaga. As in talaga nakatutok ka talaga dyan. Kasi every time, minsan, talagang yung ano niyan talaga pwede magbago anytime yung routine. Kunyari, nagbigay ka ng drugs, biglang tapos biglang mamaya pwede yung mag-arrest anytime. No? Mag-flatline yung bigla, tapos magsi-CPR na naman kayo. No? Parang CPR
May
ni
Jupiter ka
Annalyn
na?
na
May Jupiter ako.
so may mga nanonood pa sa inyo guys yan, no? Baka mamaya may kapatid pala si Annalyn dito nakakahiya.
May
No?
bar
Hindi
dito.
ko alam. So, di ba yung
Wala, may
parang
bar sa
napanood ko lang
malapit.
yun
Ba't
sa
di mo
ano sa
nakuha?
abot kamay ang pangarap sa pinan na na gusto niya i-pump, no? Ang tagal-tagal niya, 30 minutes na siya ng CPR. So hindi pwede yun kasi usually more than 30 minutes kasi actually sa ibang institution tumatanggap nag-CPR sila hanggang kailan
Ay,
gusto ng
kinuha ko.
relative. Pero kasi technically,
Isa
ang
lang
buhay
yung
na ng
nakita
brain,
ko.
15 minutes lang. Walang oxygen perfusion sa heart at saka sa brain. No? By 15 minutes, ano na yan. Ano na yan, patay na yan. No? So relatively, kung mabuhay mo yan, or mapapump mo yung sulay yung patient. No? So, ano, ethics, kasi bakit mas makapinuhay? Wala na, naging miserable lang sila. I have this patient, nag-arrhythmia siya. As in talagang arrhythmia, pero sadly sa public hospital, sobrang bida-bida ko na. Talagang yung patient ko from flatline, nagkaroon ng arrhythmia. No? So na-convert ko siya. No? So CPR, ganyan. Tapos, sabi ko doon sa relative, gusto niyo po ba, para paryentihin natin ang patient, para po masave natin yung patient. Subukan po natin. E di nung pumayag na, e di nakaano na ako, nakaposisyon na yun. All clear, everybody clear. Yun eh. Yun magkukuryente ka na. Bigla ba namang hindi gumagana yung hindi gumagana yung yung machine. Sobrang nakakahiya kasi nakagano na ako. Tapos ayaw pumuryente. Shit, anong gagawin natin? Ano sasabihin natin sa relative? Ayun, hanggang sa nag-arrest na lang yung patient kasi after nun, dahil sa sobrang tagal, magka-flat lang din. Kaya dapat mabilis ang bigay ng mga ganitong drug kasi pag hindi yan na pag hindi kinaya ng puso na yung arrhythmia niya, yung irregular rating niya, pwede yung mag-flat. No? Sobrang action niya, masaya yan. Actually. May one time naman, may patient ako, mamaya, SVT, no? Adenosine, mamaya na. So, isisave ko na yung kwento ko sa next. Okay? So, talol. So, ito naman, it is used for the maintenance of sinus shrinking in patients with atrial fibrillation also, and treatment for supraventricular and ventricular arrhythmias in the pediatric age group. So, pakitandaan lang that sotalol is previously classified as beta blocker. Kaya siya sotalol, no? But due to the further investigation, no, that it has both beta blocker and action protection potential prolonging. That's why, since it has more action potential prolonging than beta blocking activity, it is reclassified as category 3 or class. Okay? Kaya siya sotalol. Hindi siya nilagay sa beta blockers. Lopetolide is also effective for sinus shrinking in patients with atrial fibrillation and for the maintenance of normal sinus shrinking in patients with atrial fibrillation. Yan, Ibutilide, it is used for the acute conversion of atrial flutter and atrial fibrillation into normal sinus rhythm. So, ito yung atrial flutter, no? Yung para siyang ngipin ng lagare. No? Kaya, yan, atrial flutter. Pag atrial flutter, ganyan. And pag nagbigay ka ng Ibutilide from atrial flutter, makakonvert siya to sinus rhythm. Amazing, di ba? Next group, we have calcium channel blocker. So calcium channel blocker blocks the cardiac calcium current that slows it slows the production in regions where the action potential of stroke is calcium dependent, especially in SA and AB groups. And only non-dihydropyridines are included, verapamil and diltiazem. Verapamil is the prototype drug. Initially, verapamil is introduced as an anti-anginal agent. However, nakita na it is more used as a anti-angiogenic agent, no? And can be used to terminate supraventricular tachycardia. Yung supraventricular tachycardia is yung heart rate niyan tumaabot hanggang 160 above, no? Kahit 200. So I remember, no, regarding supraventricular tachycardia, yung ano niyan, hindi na masyadong mabasa, ganun na lang yung heart rate na sobrang bilis. And pag nag-persist yun, darating sa point, para siyang ang exhalation ganyan sa mga patients ko, no? O sa relative, na pag ganyan nagpapakonsent ako, no, sa SBT, ma'am, para po yan tumatakbo yung patient. Pag kayo, ma'am, tumakbo, hindi nyo naman kaya tumakbo ng dire-diretso, no? Darating sa point na papagod kayo. Pag napagod kayo, titigil kayo. No, ganun din po ang puso, no? Pag tumigil ang puso, pag napagod ang puso, titigil yan. No? So, supraventricular tachycardia, ang ano dyan is, ang first line is adenosine, no? So, medical management. Pero kung hindi talaga, pag hypotensive ang patient, walang BP, no? We can give supraventricular, yung cardioversion, yung nagko-kuryente. So, yung kuryente, di ba sa artista, at sa mga hindi kasi pwede ikaw mag-kuryente ng flat line. No? Hindi yan totoo. Sa mga TV na napapanood nyo. Dapat meron yung SVT or ventricular tachycardia before ka mag-kuryente. And the first time na pinatry ako cardioverse, parang hindi ko siya nakahawakan masyado. Parang ako din mismo na kuryente nila at. Parang ang lakas kasi talaga niya, para talaga siyang gano'n. Tapos talaga masusunog talaga yung balat ng patient. Kasi talaga makikita mo lang gumaganon yung patient talaga. Oo. So there is one patient, no, that I encountered. Dumating siya, nangihina siya, diaphoretic siya, nangihina talaga. Tapos medyo sumasakit ng dibdib niya. Nung in-ECG ko siya, nag-a-arrhythmia siya, SVT, supraventricular tachycardia. So that time, hypotensive, wala siyang BP. So nag-cardiovert. Sinidate ko lang, pinaantok ko lang ng konti, pero medyo gising siya ng konti. Kinuryente ka siya. Tapos, gumana na siya, kumaray siya. Tapos isa pa. Tapos after nun, nag-normalize. Ina-advise ko na admission aso, ayaw magpa-admit. Kinabukasan, di ba COVID nung time? Naka-cover naman ako. Tapos nag-grocery ako. Tapos sabi, nung time na yun, nakasalubog ko yung anak niya. Tapos parang sabi niya bigla sa akin, hello po, Doc. Tapos sabi ko, ha? Paano naman nga ako na-identify? Nakapambahay ako, ganyan. So, identify niya parang ako. Nagawa ko na lang, nakapasa kay nanay niya. Sabi niya, kumusta na yung nanay mo? Ganyan. Ay, okay naman po, Doc. Ang lakas na nga po ulit kumain. Yan, babaw. So, ayun, hindi na po na napala yung patient na yun. Pero ideally, after I read niya, dapat ina-admit yung mga yan. Don't worry guys, 10 slides na lang. So, sobrang marami akong experiences pagdating sa mga arrhythmias, guys. Kaya, ganyan na lang ang excitedness ko sa mga ganun. So, there are also anti-arrhythmic drugs that we can use, no? The latest in the edition is ivabradine. So it is now classified as class 0. So it is HCN is hyperpolarization activated cyclic nucleotide gated channel blocker. So it inhibits the funny current yan, no? The IF or the funny current, reducing the SA node phase 4 pacemaker depolarization rate, therefore reducing the heart rate. Adenosine, ito yung first line natin, no? It is a drug of choice for the conversion of paroxysmal supraventricular tachycardia to serious rhythm. However, side effect includes flushing, SOB, and chest burning. Kaya usually, itong adenosine, dinidingin pa to with 20 ml of plain NSS, no? Kasi mainit yan sa pwede ka magka-IV burn dyan. And usually, para mabilis ang administration, kailangan mo iangat yung arm ng patient, no? Para mabilis pumunta yung yung gamot sa heart. Ayan, ito pala yung supraventricular tachycardia, napaaga yung kwento ko, sorry guys. No? So yun nga, no? Ang adenosine, no? Ang goal natin kasi is to ma-convert natin siya into regular sinus rhythm. So makikita niyo yung patient, bigla na lang mag-convert into ganyan, no? So sobrang bilis, no? To regular sinus rhythm, no? In that case, no? Patient needs admission, ma-investigate what is the cause of SVT. It can be infection, electrolyte imbalance, autoimmune disease, and others. Amazing, di ba? Magnesium, mechanism is unknown, but it influences sodium potassium ATPase, sodium channels, potassium channels, and calcium channels. And this can be used for patients with digitalis-induced arrhythmias and torsade de poix. So torsade de poix is a polymorphic ventricular tachycardia with twisting complex morphology. So makikita niyo, no? It looks like this, no? Para siyang yung twinist na na ribbon. So pag nakakita kami ng ganito, possible yan, it is torsade de poix. And usually we give magnesium, IV magnesium to these patients. So next we have ranolazine. So it is classified under class 1D, no? So given class 1, it is a blocker of sodium, no? So it is dependent on the multiple ion channel, pero more on the sodium blockage than the potassium blockage. Okay, the net effect depends on the relative contribution of the sodium L-type channel and the KR current channel no, to the action potential depolarization. Vernacular is the multi-ion channel blocker. So it blocks several voltage dependent and frequency blocks, no? Like the early and late components of the sodium channel, the muscarinic part of the current, and the early activating potassium channels. So it is used for the termination of atrial fibrillation with no or minimal structural heart disease. So this drug is approved in Europe, but not yet in FDA. So that's it for today. Are there any questions? Hopefully mas na nakapag-add ka ng additional information sa inyo with regards to anti-arrhythmia, no? You can mas maintindihan yan when you proceed to med school, no? And there's so much na kailangan talaga na extensive na na dapat alamin. Hindi lahat ng doctors, no, naiintindihan yan. Pero yun nga, it is important na alam na kung saan nag-work in different classes para mas maalala niyo siya. Okay? So we'll proceed tomorrow yung agents for hyperlipidemia, autocoids, blood drugs, and asthma and COPD. So we'll see you. I'll see you tomorrow. Are there any questions from the TNC subscribers?
None.
Mukha namang wala naman silang none po, sir. Yeah, thank you very much, ma'am. From UPAC, no? Ma'am Joanna from saying in behalf of UPAC students. How about from Iloilo and Cagayan de Oro? Are there any clarification? None. From UI, thank you, Ma'am Ria. Ayan. From Cagayan de Oro, are there any clarification? Okay, yan. Thank you very much, ma'am. Norhani and Ariel po. So I'll see you tomorrow. Thank you very much. Thank you very much.